Welcome to the eGPlearning update, where we're going to catch you up on everything that's been happening in general practice. And there has been so much that's happened in the past few weeks that, well, we hope you stick around for all of it because you're not going to miss what we're covering in today's episode. So let's get cracking as we tech enhance your primary care and learning. Hello, EGP learners, and welcome to this episode where we're about to update you on everything that's been happening in general practice. And there has been loads, from conferences, from strikes, from advice and guidance, from various other things like renaming clinicians, and a little bit more as well. Hasn't there, Andy?
Yeah, there's been a lot going on. I'm just still adjusting to the Thursday evening surgery schedule for eGPlearning, but we'll get there. We'll get there in the end. Hoping we're carrying some of those viewers through from Saturday. I can see Miss Melody's joined us already. Yeah, excited to discuss the news for the last 2 weeks in general practice. But I know, Gandhi, you are normally a great sort of advocate for System 1. There is another clinical record system out there. There are more than another. There's several, but there is EMIS, who locally they're the big rival for System 1. And I know that you've been doing a little bit of moonlighting at the EMIS National User Group. So I was just wanting to ask you a little bit about that, because I've worked with you with the System 1 guys, but not really had much contact with EMIS. How did you find that experience?
It was a really cool experience, actually. So this was the second time I've been invited back to the EMIS NUG, and I really appreciate the team who run it for doing so. So I guess just to clarify, the EMIS NUG is their national user group. That is separate to EMIS, the company, although obviously they have some links in terms of what they do to provide the content and all that kind of stuff and things. And I had a great time, personally. I really enjoyed it. It was a little bit off the beaten track. So it was Tottenham Hotspur Stadium, which coming from Nottingham was a little bit trickier than I planned. But actually it wasn't as bad as I thought it was going to be as well. So that's a positive. And got to meet some really cool people, caught up with some of the friends of the channel kind of thing. So definitely the team from Ardens, from Primary Care IT, from Practice Index, Crescendo, that kind of stuff. Loads of cool people and stuff that we've had on the channel, and potentially some newer faces as well. So GP Automate and a couple of other people I had a really cool opportunity to meet as well. I got asked to speak about the future trends of digital stuff in general practice. So I basically called the session everything you need to know about digital use apart from EMIS. And it was so much fun. It really was a nice stage, really cool tech. They showed me how you have really proper good tech when you're doing a presentation and that kind of stuff. And we covered loads of cool things in terms of what's coming in general practice. So absolutely how to use systems. We talked about dictation. We talked about AI, automation, data, various other things as well. And even content creation, Andy. So
fantastic.
That little thing that you're working away on the background that hopefully many of our EGP learners will get to see soon as well. So that was really cool. I got to see EMIS X, so the new system and their plans for it. I did a little bit of a faux pas, and I apologize to everyone for it, in the sense that I did record the session and slightly publish it very briefly. And again, apologies to the organisers for doing that. I didn't actually realise I wasn't meant to. So, but that's gone. I'm afraid you can't see it anymore. Yes. But it was an amazing session and a testament to the NUG, I think, in terms of how they organised a conference, because I know the previous year was much smaller. This was much bigger, much grander. I thought it was a really well conference and I had a great time. So, yeah. Hopefully they will invite me back, maybe.
Yeah, sounds fantastic. And I guess, are there some links that you'll put in the show notes if people want to catch up with what happened at that event, or is there anything that they can?
I don't think there is anything I can specifically say. I mean, they can go have a look at the EMIS NUG website. I would definitely recommend doing that, because they had some cool things that they were sharing, and there's definitely going to be one, I'm assuming, next year as well. Don't know where, don't know when yet, but I'm sure they're working up for it. And like I said, maybe they'll invite me back.
Yeah, that's great. It almost feels like another episode could be done on that, and I almost want to enter into what do you think about EMIS, versus System 1 and that big debate? It's a bit like Android versus Apple, isn't it? But let's not go there today.
That would be a very contentious episode, wouldn't it? I think we would need other people on the stream for that, because to be honest, we're a little bit biased when it comes to that. Obviously, both of us use System 1, and obviously I run the System 1 Facebook users group. So let's be honest, I have a declaration of interest there. But yeah, I think that would be a cool episode though. EMIS versus System 1. Actually, in fact, me and Mike did that a while back. So we did a comparison of the pros and cons of what you can do in EMIS versus System 1 and stuff. And that's a great episode if people want to check it out. And obviously from that, me and Mike have created our courses to help clinicians use TPP, System 1 and EMIS as well, which as ever, links are on eGPlearning if you want to jump in and have a look at that and stuff.
Yeah, probably time for a rematch. I mean, most YouTubers, you can do the same thing every year. Stick 2023 after it, and you'll get viewers again.
Thanks, yeah.
There's always new features coming along. So yeah, but I guess there's been a lot more happening as well. The next topic that we've got on our Google Docs to talk about was the strikes. So there's been further developments. So we've had junior doctors striking regularly over the past few months. Consultants have begun to strike this month. I think, is it the first time that they've been striking together, Gandhi? So has that happened before?
No, so both groups have gone on strike individually, but you're right. I think this is the first time where they've coincided, where the strikes have happened at the same time. And as a result of that, many places have gone down to what they call Christmas Day cover as a result of it. So basically, go ships in terms of the cover that's available as a result of it, and I guess that can be really challenging because obviously losing both types of workforce can be really difficult. Obviously the government feels their view is very different to, I guess, the professions in terms of the impact that should be having and what is safety, and we're going to come to an article that talks about that in a second. But actually it sounds like there's more people joining them, doesn't it, Andy?
Yeah, I mean, I guess the other group of doctors are the sort of career grade doctors, the specialist and associate specialists, but essentially staff grade, I guess, is what we'd say in plain speak. The staff grade doctors, they're not juniors, they're not consultants, but there are a large number of them, and the BMA is going to ballot them in the near future about strike action. They are talking about a 31% real terms pay cut over the last 15 years, which is similar sorts of levels to junior doctors, and that this just isn't right. They are not valued, and I mean, I think it's probably likely that they'll take strike action as well. Other grades of doctors have voted overwhelmingly in favour of strike action, and I suspect this group will be the same. I wonder if they'll be able to all strike simultaneously. That might take us below Christmas Day cover, although I guess some people remain in the hospital and on those skeleton crew rotors to staff things. But yeah, interesting development, not unexpected. Any thoughts, Gandhi?
No, I mean, like you said, I think it's likely they will probably vote to strike. It seems like there's a strong emotion behind that. That will definitely raise questions about capacities for the hospital trusts and that kind of stuff to then provide cover on future strikes if they were to continue to happen. And I guess we're not seeing any change from the government in terms of their perception on that. In fact, it seems like that they're digging their heels in even more with some of the changes they're planning, isn't it, Andy?
Yeah, which brings us to the next story we were going to look at. Government launches consultation on changing NHS strike legislation. So I gather that currently those minimum sort of staffing levels are down to local agreements between commissioners and kind of local BMA representatives about what level of cover is acceptable, and the government are proposing to legislate so that the profession is obliged to provide a minimum service level during strikes, and that is something that will be set at a more national level. And I think the intention is to weaken the impact of strikes. I guess the government would say limit the negative impacts on patients and maintains patient safety. And I guess the profession might suggest that this is to declaw the profession in its ability to use the withdrawal of its labour to make its point and advocate for better paying conditions for the profession and for those people receiving services in the NHS. Be really interesting to see how this goes. It's obviously opposed by medical representative bodies, but it'll be interesting to see where this lands.
I know, and I think it's that whole aspect that, are they taking this because then if they do push this through, then that means that actually the strikes will have less of an impact and therefore they don't have to worry about it. I wonder if that's part of the reasoning. Although I think it may be, not necessarily what they're thinking. Is it actually the fact that minimum staffing is, actually more than what we actually have currently. So, is it that actually by setting a minimum staffing level on some days, particularly during winter, that may actually be more than what we have on a normal daily basis? So actually it could end up being more of an issue in terms of actual underlying staffing levels.
Yeah, and also
Who
actually
knows?
just raising and talking about this issue may sort of serve to help the government make a point, or to make noise about safe staffing levels. And and it may be that actually what's happening now is adequate to maintain safety, but making these sorts of claims and plans, creates that noise to undermine the doctor's position. There's all a big sort of media game going on here, isn't there, for hearts and minds of people and patients, and it could also be part of that. But an interesting position. I know there are other professions which are not permitted to strike, like the police force, for example, and the army. It doesn't look like they're suggesting going that far, although some people, I've heard it. I've heard the case made, in some places, that essential services like the NHS, maybe if the police can't strike, maybe they shouldn't either. But I certainly wouldn't go that far at all.
And interestingly, obviously, GPs technically can't strike either. And we've covered that in previous episodes about what actually striking would mean in general practice. Interesting to know, I still come across many of the forums where people still don't understand that actually GPs can't strike in the same way that the hospital doctors are currently striking. And obviously that has an impact in terms of what potential options the general practice profession has in terms of future industrial action, which is probably the better way of describing it. Because we know that there are new potential contracts coming, and we're hearing they're not going to be as seismic changes as many of us anticipate we need to help maintain general practice. So it'd be interesting to see what happens from that point of view, wouldn't it, Andy?
Well, I guess we're hearing talk of sort of placeholder contracts, aren't we, to take us forward over one or a small number of years, whilst the government have a really good think about the direction they want to go with general practice and primary care, hopefully in consultation with our representative bodies at the BMA GPC and RCGP. But we will see about that. And just coming back to your point about GPs, it's not being clear whether they can strike or not. That's because actually GP practices hold contracts to provide services to NHS patients. It's not a case that individual GPs are employed by the NHS as an employer, as is the case for those employees working at NHS hospital trusts. So that puts GP partners in particular in a sort of tricky position, because they're not employed to provide those services. They are commissioned to provide those services. So if they withdraw their labor, then that could be a breach of contract. They could have that contract taken away. They could have other penalties applied, in terms of the contract management. So it is quite different for GPs and quite tricky. So we will see how that develops. But I guess keeping pace with the stories, the next story that we thought was interesting was about physicians associates, and the BMA is looking to change the highly misleading, air quotes, physician associate title, which I think is interesting, actually. And you work with some physician associates in your primary care network, in your practice, Gandhi. So I do wonder what they think about this, actually, and what they're called. The proposal here is to change the name back to physician assistants, which it was apparently quite prior to about sort of 2014, 2015 when the title changed. And I guess that would put it more in line with things like teaching assistants, that support, sort of teachers in schools. But yeah, what do your physician associates think about this, or what do you think about it, Gandhi?
I think it stirred up a lot of emotion, hasn't it? And there's been a few news articles when it comes to PAs in general practice. Unfortunately, there was that recent episode where a patient suffered some harm because they had seen a PA in their practice, and those questions around the supervision and the structure of how that worked, and could that have been prevented if there had been different models in place. As ever, I always think some of this always comes down to individuals versus roles versus capabilities and that kind of stuff. I've not actually talked about the naming with our PA. So I do supervision for our local network PAs. And as you mentioned, I've got 2 PAs in our practice and stuff who I think are excellent at what they do. They are well supported and well supervised to make sure that they can practice effectively and support our patients, and recognize that when there are difficulties, they need to ask for help. And I think that's how it should work. They are absolutely part of the multidisciplinary team. I think the reason why this is continuing to be a problem is there are definitely cases where some clinicians have potentially acted in some capacity above what their role may be, or not clarified what that role may be. And there's also this question, like you say, about patients mistaking associates for doctors or other types of roles, and then that being a question about whether that's appropriate, sensible, and what the patients would want as well. And as a result of that, like you said, is it the name that has some complexity within this? That seems to be the tack that the BMA in particular have taken on this, and that actually that's where they feel one of the key changes needs to happen, especially as there's plans to obviously engage those roles within the RCP kind of certification process, so that that kind of structure. So it's a contentious issue, I think, and I think there's many clinicians out there probably being dragged into this who feel really uncomfortable talking about it. I think there's also some very vocal voices either side of the argument in terms of what that means. And I think it's really important that we also remember at the heart of this are people at the end of the day. So I think it's going to be interesting to see how this develops. I don't think this is a story that we're not going to be covering again at some point in the near future, to be honest, Andy. It's going to keep coming through, isn't it?
Yeah, and I think we're looking at sort of regulation coming in next year, or increased regulation around these roles coming in. So it'd be interesting to see if the naming is revisited or clarified then. I think this associate it's an interesting word, isn't it? Because we were just talking about associate specialist doctors, potentially striking. So it is a word which is often connected with people with medical degrees, that term associate. So it does have those kind of connotations, as does physician. Assistant may be clearer. I don't know, but it's one of those. I don't work with directly with these roles, so I feel a little bit underqualified to comment.
And I think there's something about also the employing organizations having a responsibility here. So one of the things I know that we're hearing more and more of is that there is less locum work around for GPs, and that actually some organizations, particularly out of hours organizations, seem to be favoring more towards associate health professionals instead of employing GPs to cover their shifts, and not actually potentially being clear about who is assessing and sorting out the patients and stuff. And the reasons, I guess, are obvious, that those clinicians are generally cheaper to hire compared to a GP.
Although we are seeing some noise about particularly hospital posts where physician associate terms and conditions and responsibilities and pay are displayed next to the terms and conditions and responsibilities and pay of junior doctors, and we're seeing adverts for physician associate roles where they're paying more than junior doctors who potentially have higher levels of responsibility and professional regulation around their roles as well. So that's just another dimension to it. Sorry to interrupt, Gandhi.
No, definitely, it's a valid point. And like you say, I think it's the dichotomy that we see in terms of physicians associates in secondary care versus physicians associates in primary care. There are, I think, differences that occur in that situation. And is it that primary care is more effective at providing some of that supervision and that structure? And obviously GPs are considered at the top of their kind of level in terms of their training schemes compared to obviously in hospital base. You've got a much more layered structure that occurs with the journey of the clinicians within that route and stuff. So I think, like I said, I think this is not something that's going to go away. I think this is something that does need some clarity, and it needs some discussion as well, whether or not the organizations plan to have those discussions, or whether they tend to use the media as their discussion point instead. Will be an interesting thing for, I think, for many of us to see. But definitely keen to hear what many of you eGP learners out there think. So if you do have a perspective on this you want to add in, do let us know. If you're joining us live or if you're watching this on the replay, absolutely stick it in the comments, because we would like to know. And would you feel that this should be a bigger discussion that we need to potentially even support and stuff? The reason that I also asked this is I've also asked a poll. So if you are watching us on YouTube, you may have seen the poll about what should PAs be called. So I kind of suggested physician's associates, physician's assistants, practitioner assistants, and practitioner associates. So far, we got a 50-50. Both of the ones with associates seem to be winning, but that's only a few votes. So maybe jump in and join in and cast your vote on that kind of area and stuff. Speaking of PAs, one organization had a real perspective of possibly how that might work was some of the private organizations do seem to be using those. And we're going to talk about one in particular that has been, I guess, the rise and fall in general practice, hasn't it, Andy?
Yeah, so we're gonna talk briefly about Babylon. I'm quite a fan of Wired magazine, actually. So it's a magazine. I've had a subscription for this magazine for over a decade, Gandhi, and they do some really quite nice kind of in-depth journalism, particularly in the technology area. And they did an article this week, I think it came out, about Babylon Health, just kind of charting their rise and fall. And it's a really nice article if people want to follow the link and have a look. Within the article, it has their kind of hyperlinks that links out to all of those kind of old stories about Babylon over the years. Babylon recently gone. They've been disposing of their UK and global assets and winding up, really. But long-time friend of the show, I guess. We've talked more about Babylon than many other companies, I think. So I think we'll be sad to see them go. Just so people know what to expect from the article, sort of tells the story of Babylon from the perspective of an NHS consultant who joined them near the beginning. Obviously, Babylon founded by a chap called Ali Parser, who actually founded Circle Health, and actually Circle Health went on to be owned by Operos Health, which is a subsidiary of a large American health company. And actually, they recently exited the market and sold Circle Health to a Middle Eastern consortium, I think. So that's interesting. But yeah, they wanted to do for healthcare what Google did with information to make healthcare freely and easily available to everyone. So quite big, lofty goals. The article talks about really, really rapid expansion, very interesting. People being hired, not knowing what team they're assigned to, wandering around the offices, looking for a team to join and a job to do. It sounds like people who worked with them found that some of the AI algorithms were a little bit less sophisticated or developed, as potentially was being talked about by the company. This is all in the article. Don't sue eGPlearning. Go after Wired if anyone's out there acting for Babylon. Teams of doctors being asked questions like, what's the probability of a patient with 2 weeks of jaundice having hepatitis? And I think those sorts of questions point potentially to a company that perhaps wasn't using sort of big data to get insights into health in the way that maybe was being described, and when actually we're using traditional clinicians to make judgments to power their knowledge graphs and so forth. Expanded into other countries, struggled in the US, which was actually quite a mature market with other companies doing similar things. A large part of what they actually did was telehealth, wasn't it, Gandhi? I remember everyone got quite worried about their GP at hand service when they opened in London, linked to an NHS practice. That was interesting. Do you remember that story, Gandhi?
It was. So there was practice in Fulham. There was very much concerns that they would be cherry picking, and because they didn't really have a border at that time, because obviously the borders in terms of boundaries of practice and stuff was taken away around about that time as well, which potentially propagated the whole rise of Babylon. But then obviously, the change that happened was with COVID, when actually many practices themselves went to remote access in terms of how they engage with patients, and actually whether that really impacted Babylon, because all of a sudden, actually almost every practice across the country was then offering remote consultations to their patients in the flick of a switch, and obviously then that charted down some of the impacts. The article also mentions the fact that, Ali Pass himself has been on record as saying that they lose money for every NHS patient that they have, and maybe that speaks to some of the complexity that exists within general practice that you and I often talk about, that many organizations seem to kind of assume isn't there. People seem to think that general practice is easy. Let's be honest, if it was easy, why are these companies not able to stick around then? There's an aspect of this that goes against that whole argument that private business can make general practice better. It could do, but I think it's just how you perceive it and how you work it. And it's not a kind of business that works for significant profit that some of these organizations are obviously trying to make and stuff in order to remain there. And we're seeing that because Babylon are leaving, Operos are leaving. You know, it's taken a few years' journey for these organizations, but it doesn't seem to be going the way they planned.
Yeah, and the article actually reminds us that IBM, offloaded Watson Health, which was their AI healthcare division, which is really interesting, and it points to other companies such as Olive AI and Sensine Health, who also have recently sort of exited that UK health AI market. So it does look like it's a market where it's not necessarily as easy as big business might think to make profit and survive. So really interesting article. I mean, I was left thinking, because we're quite optimistic about technology generally, aren't we, Gandhi? I think we're realistic, but optimistic about the potential. And I was left thinking, well, maybe this is like the early days of the internet, and maybe actually these initial companies and projects are like the kind of MySpace and the Friendsters, and hopefully the Facebooks are waiting in the wing to or yet to be founded or come to scale, and will actually deliver something really useful in terms of AI and tech in healthcare. But anyway, really interesting story. If people want to have a look, I found it really interesting. Reminded us of the time that Babylon threatened to sue CQC, which was interesting. And they link out to all of these articles just to kind of allow you to have a look if you want to. So it's really, really interesting. Really interesting article. I guess the final stories that we thought were interesting, and actually so interesting that we'll probably do a separate episode to look into these, because we're at sort of 26 minutes now, aiming for 30-minute episodes on a Thursday evening. So we'll roll over into a recorded episode. But there's been a lot of talk in the last 2 days, actually, about advice and guidance and the expansion of the advice and guidance service within the NHS. It looks like, I think NHS England have been working with the Royal College of Physicians in particular, and other clinical leaders, they say, to develop a new strategy for reducing unnecessary outpatient appointments, and an increased role for advice and guidance is part of that. I guess we shouldn't leave people just wondering what A&G is or what advice and guidance is. So I don't know, are you able to give a very brief explanation, Gandhi?
Yeah, sure. So most people will know that when you're seeing potentially in general practice, if you've reached the limit of what the practice themselves feel they can offer you, then they will refer you on to the hospital for secondary care. And that's often the outpatient department, unless it's an emergency thing, in which case that'll be straight to the hospital. But advice guidance is kind of this hybrid version where you can ask for advice about within that particular specialty to the specialists themselves, and then often you get a reply normally within a week or so, seems to be the average time frame, and that will then outline a plan. And that obviously has pros and cons in terms of time frames, in terms of access to information, but also has cons in terms of what might that response be. It's obviously not a synchronous discussion, it's asynchronous, so you're presenting the information. It's that perception of the clinician based off the information they've got, how well that's received by the other person. They don't have that ability to clarify information. So think of it kind of like an online consultation in some ways, in terms of how that works. And obviously then there's the question of what is the output? So how does that work in terms of the advice that's actually given? Does that mean more tests? Are those tests that can be done in general practice or not? Or actually is it something that needs to be converted, because appropriately should be seen by the specialty, into an outpatient appointment? And then how does that process sometimes work as well? So it's a rather interesting thing that has been around for a lot longer than people think, in terms of its concept and stuff, and it definitely seems to be the plan of direction for the NHS in the near future. And I guess it's a question of whether or not patients agree with that. I think there's definitely a question about whether the profession agrees with that, but also do our secondary care colleagues agree with that? Because actually this is a different way that they will have to do work, and whilst it may mean that they potentially will do less outpatient appointments or speed up that outpatient time frame, it's a different kind of work that they will have to do, and some of them may not be happy about it, to be honest.
Yeah, these are interesting stories. The way this is playing out, I think I get the sense that there may be some confusion here, or they may be confusing advice and guidance, a service to support GPs to avoid unnecessary referrals, where they know that they might be able to manage people in primary care if they had a little bit more support and advice from specialists, with something that is quite different, which is referral triage and referral management, which is about reducing the number of referrals, essentially. And I get the feeling that these two things are potentially being conflated in this work that's happening here, and I think that there's some danger in that. But I guess we'll start to pick this apart a little bit more in the next episode.
Yep. So if you do want to see that discussion, which me and Andy have had around what advice and guidance may mean in more depth and more information, and some pros, some cons, some various other things, make sure you check out this episode right here. Alternatively, you can check out more content that we've got for you from eGPlearning that's probably coming up right here. And as always, we're here to help tech enhance your primary care and learning. We will catch you in the next episode, hopefully for some more discussions and stuff as we continue to try and help you in this lovely world of general practice. Catch you later.